Welcome to Knowledge on the Go, where we explore leading practices emerging through Vizient's performance improvement programs. I'm Laura Hoffman, your program host and Senior PI Program Director at Vizient. We know immobility is bad for patients, but why is it so bad? Nancy McGahn, Enterprise Safety Mobility Manager at Intermountain Health, joins us to discuss mobility is medicine. Nancy, thanks so much for joining us today.
I'm happy to be here.
All right, Nancy, describe the Intermountain Mobility is Medicine program and its origin.
What we have is the Safe Mobility Program, and it integrates fall prevention, safe patient handling, and patient mobility programs so that we don't silo that work and cause unintended harm. What we've seen historically in healthcare is focus solely on fall prevention, and we don't let our patients move. We focus on preventing injuries to our caregivers and using technology. Also, maybe that could limit our patients' mobility. When done properly, it can actually increase it, but it can be done in a way where we're always moving our patients passively and not allowing them to do activity. We could focus on just mobility and ignore the risks that come with mobilizing unsafely. If the patient has a high fall risk or has real mobility limitations, the risks to our caregivers who have to move and handle patients that can't move very well on their own. The safe mobility approach helps us to make sure we're meeting the vision of healthcare and not ignoring any one area.
The program is designed to educate the healthcare worker. Can you tell me more about how that works?
In our education as nurses, respiratory therapists, and even to some small degree as physical and occupational therapists, and I'm a physical therapist by background, we don't talk about the extreme harms of immobility. There's physiology behind it. What happens is that if we are so afraid to mobilize our patients, we'll just not do it. It's fearful for us. What we need to do is fill those knowledge gaps once people are already in their careers right now, because they really don't have that knowledge. So this program initially fills the knowledge gap, but we also have to give them the tools and the resources so that even if they understand the harms of mobility, they'll feel safe moving their patients. If the patient doesn't feel safe, if we as caregivers don't feel safe, if their families don't think they're safe, they stop moving. And that's not just in hospitals. That's at home. Our older adults at home, when they feel like they're going to fall, often stop moving, and that increases their risk of falling.
Do you tailor the program specifically for staff just beyond licensed nurses?
We really do need to hit all populations of people. We try with all of our education, if we can, to make it at that language level that almost all adults are going to understand, not just for our caregivers. Of some people, English isn't their first language, but that's also our patients and our families. We want to dive into why mobility is so harmful, and not moving increases your risk of falling because your muscles get weaker, your bones start to degrade, you're more likely to get blood clots, your body fluids are in your thoracic cavity, they compress your organs a little in your bladder, and so you have a sense of urgency, which was a big reason people fall in the hospital setting. There's also the big issue with depression. When people are in a hospital bed all day, all night, for several days in a row, it's mentally draining. Just getting someone out of the room, eating at a table and it's with a regular chair if they can. We can all imagine times where we've been really isolated or sick in our room. And when you first get to go outside and feel the sunlight, it's very emotionally uplifting. And there's research that shows that walking with a decent heart rate 3 times a week for 30 minutes is as good as SSRIs for preventing and treating depression. It's a huge thing. I can't remember the name of the physician, but he said, if we could put exercise and mobility in a pill, it would be the most prescribed prescription in the world. Understanding that when we don't move, we're harming our patients and we're increasing all those hospital-acquired conditions that we do many things to prevent. And the biggest of all is independence loss. We're often having patients that should have gone home that are going to post-acute care, whether that be a skilled nursing facility or a rehab facility. And then often in the skilled nursing, they're not allowed to move much there. So if we can get them home, get them independent, we're majorly helping improve their lives.
I love the analogy about the patient mobility being in a pill. You talked about the mobility program being a threefold cycle. Is it tough to teach that immobility is a cycle, knowing that it's harmful, yet it's necessary to get those patients moving?
It's a real friction point between the balance of falls and mobility. A really good thing to think about that's current news is our astronauts that return to Earth. Gravity alone, even if they're not walking, but they're standing and bearing weight, that's super important for the human body. being in space is extreme lack of gravity. But when you're laying in bed and you're parallel to the ground, essentially, and you're not getting gravity through your bones and your muscles, you're harming yourself to a lesser extent, but to the same way as our astronauts. Any mobility can help. So the biggest thing is to have 3 different assessments. And one is focusing on how mobile is this patient? What can they do for themselves? And depending on what they can do, what kinds of safe patient handling technology or canes or crutches would we want to use to help that person maximize their mobility? So let's say someone can sit at the edge of the bed, but they're struggling to stand up all the way. There's standing devices, some that power them up and some that they can pull themselves to standing, that then they can weight bear. They can get those muscles working again. They can get prepared using equipment that they can't fall in. You have the best of both worlds if you have a mobility assessment that tells you what kind of safe patient handling technology you need. You also need a fall risk assessment. If the patient has no cognitive awareness or safety awareness, has dizziness, any kind of fear of falling, you also want to mitigate the fall prevention strategies. If they don't have good footwear, if they need a hearing aid, they need their glasses, they're not getting proper nutrition because they don't have their teeth. All of those things fall into fall risk. So we need to look at the fall risk in addition to the mobility or the mobility related fall risk. And then you need a goal for mobility. If you don't have a mobility goal for that patient based on their fall and mobility assessments, then they still might not mobilize. We might have the tools, the equipment, the training. It needs to be built into the care plan for our nurses, our PCTs. In some instances, even our transporters and our respiratory therapists will help mobilize. You have to give them these tools so they can do it safely and set the goals so it happens.
Can you give me an example of any special populations that this mobility is medicine program would help?
When you use the safe mobility approach, it works for everybody, including some of our more challenging patients, like our adult and pediatric patients with very high BMI. If they're immobile, we can now still mobilize them with the proper technology. We can have success. We've had patients that come in not walking, that are walking when they leave our hospitals and go home and stay home. I can think of one gentleman who's been home for 5 years and still successfully independent. You can turn people's lives around. There would be no physical way we could do that without an assessment and without that patient handling technology. We also are seeing a tremendous amount of teenagers with very high BMIs as well. Think about the life-altering changes they may go through if they don't have access to this kind of approach. It does help everybody, including some of our most challenging patients.
When I was a nurse at the bedside, conceptually, I knew immobility was bad, and I would work a lot with our nurses' aides to help to mobilize. Yet I was still nervous and would get especially nervous with special populations that were potentially bariatric patients, and that fear of getting hurt if I mobilized my patient without consulting physical therapy first. How do you help staff overcome that fear of mobilizing patients and getting hurt?
We set our nurses up for failure in many ways because we ignored the fact that it's really hard work, that nurses and PCTs have been on the top 10 list of most injured professionals since the 1970s when the Bureau of Labor Statistics started measuring this. They have to be empowered with a nursing-driven mobility assessment so that they know how to mobilize and don't have to wait for PT or OT to come. When we first started training on this, one of my biggest excited moments early on was one of our PTs saying, now when I go to see a patient for the first time, it's not their first time out of bed. They are so much more prepared for therapy. And that's because our nurses were empowered. If the patient was admitted on a Saturday and wasn't getting PT till Monday, you don't want them sitting for 2 days. Now they need even more PT. We end up needing physical therapy in many of our patients, especially our older adults. They come in, we're afraid they're going to move, or we don't value it, so we don't do it. We don't realize the importance of it. And then they need PT and OT on the day of discharge because they've declined while they're with us. They were walking, they were independent in the community, and now for 3 days they were in the hospital, not a PT or OT candidate, and they've become one. And in most hospitals in the country, only 55% of patients see PT and or OT. If you're in a total joint hospital, it's going to be 90%. But on average, in our U.S. hospitals, only about 55% are getting PT and OT. So that other 45% still need to move, or they're going to need PT and OT. They're going to go to a skilled nursing facility or decline and take months to recover, especially our ICU patients. If we oversedate and don't mobilize them, they can have post-traumatic stress from delirium. They often go on to have a life of harm and can't return to work. That doesn't just happen in the ICU, but throughout the hospital. Mobility is one of the absolute best treatments for the prevention and treatment of delirium.
What has been the overall reaction that the staff have had to this training and education?
When we first rolled this out, and it was 2020, so we all know what was going on in healthcare then, it was decided to still do some of this education in a limited fashion. We had these mobility is medicine tip sheets, and we had 10 body systems. And we talked about the harms of low mobility or immobility on the cardiac system, the immune system, the respiratory, the muscular, the bone, and on and on and on. Each month, we talked on every nursing unit about the tool that we use in Intermountain Health called the Bedside Mobility Assessment Tool. At the end of that year, our chief nursing officer rounded all the nurses in our healthcare system, and they asked, what are the pebbles in your shoe? What do we need to do? What are your biggest barriers that we can help you with? The top 8 things that came out of thousands of interviews, and that was that we need to mobilize our patients more and we need help to do it. That education, taking that time, had tremendous impacts, and it's just a knowledge gap. I don't think a lot of people realize how harmful it is to mobilize.
Have you noticed a difference in the frequency of patients being mobilized as a result? What are your key performance indicators that are telling you that these programs are successful?
We did a few different grants throughout this process to help us develop how we're going to document mobility and therefore measure mobility and set KPIs. If it's not measured, we can't improve it. We have nursing mobility documented. We have PT and OT, and we have that all combined together so that we have the total mobility picture of that patient. And we have dashboards set up that we've set those KPIs for. The KPIs for the last 4.5 years have been what we call therapeutic ambulation of our 65 and older adults 3 times a day when they're in the hospital for a full day. There's another one that's more complicated. It's measuring mobility for our patients that are not capable of walking yet, because it's every bit as important that they maximize their mobility. When we began this, our patients were at 21% of those 65 and older adults were walking 3 times a day. And right now it's at 54% 3 times a day. Now we're at 75% 2 times a day and 88% 1 time a day. So we've seen tremendous improvement. We also teach our staff on the intent of walking, and not just the distance or where they're walking to, but the why behind it, which helps that process and that valuing of mobility over some other tasks.
So Nancy, what do you see the future of this Mobility is Medicine program?
The future's bright. I've been living in this world for 18 years, working in the safe patient handling and mobility space. And in the last few years, it's taken off on a national level. It's being a lot more recognized than it was in the past. Just last year, CMS has age-friendly care. We're coming together. We're valuing this like it deserves to be. It protects us as caregivers. It protects our patients, just like infection prevention. We will be coming up with more and more good measures of success, and I'd love to see benchmarking someday like we have with falls. We have a ways to go. We got to standardize how we measure and how we track. I really am excited for the future of this and see far less patients get disabled while they're in our care.
Well, based on the results that you've shared, your program is working. And I can certainly hear that you are passionate about mobility. Thank you so much for joining me today and helping us appreciate the delicate balance between educating staff and allaying their fears about patient mobility while empowering them to do what's best for their patients. Unfortunately, that's all the time we have to share. I'm sure Nancy and I could go on about patient mobility. Please join us for more knowledge on the go. Subscribe today, like us, and send us your comments at picollaboratives@vizientinc.com. From Vizient's PI Programs team, I'm Laura Hoffman. Have a great day.